Hello, my name is Randy, Chief Technology Officer of VDI Laboratory. In today's presentation, we're going to cover cancer diagnostics and what services VDI has to offer in this space. Now, our cancer diagnostics are context sensitive, meaning that they are for specific applications that you might be seeing in your veterinary clinic. For example, we start off with sort of what's known as the general cancer panel. These might be things that are for the dog where you really don't know what's going on. They might show signs of lethargy and appetence, or they might have suspicious masses, in which case you're trying to wonder if they are cancer or something else. We have one specific for lymphoma. These are what we call 201 and 201B. And then we have others, as you can see in this list, one for stem cell therapy. We have one specific for pericardial effusion, very special. And then we have a growing panel in the area of GI, and I'll be talking about that in another presentation. But today, we're going to be covering 201 and 201B, the general cancer panel, and the one for lymphoma. Now, our markers that we're using in most of our services for cancer is thymidine kinase type 1. It's a DNA proliferation marker. It makes the nucleotide thymine for true DNA synthesis, but through a dysregulated or abnormal proliferative cycle. And we're also looking at inflammation. In our case, it's canine-specific CRP and feline-specific haptoglobin. Now, TK1, which is an enzyme that makes the nucleotide thymine, but it does so through a dysregulated or an abnormal growth cell cycle process. So the normal way a cell makes thymine for DNA synthesis is through the de novo or new synthesis pathway. Then there is what we call the salvage pathway. And when cancer divides, it divides irregularly. It often abrupts the cell cycle, growth cycle, and then you end up what's known as exogenous DNA. The body tries to preserve everything, and so it upregulates the TK1 enzyme, brings that back into the cell for new synthesis then of DNA using this exogenous DNA to make more cancer cells, and that's kind of how it works. So this is a dysregulated DNA pathway, a hallmark of cancer. We also use inflammation. Well, why? Well, inflammation is a core part of cancer. Cancer is an inflammatory disease. In our case, we use canine-specific CRP and feline-specific haptoglobin for cats. And when you think about cancer, it begins with inflammation, and then it propagates and metastasizes, and all these processes require the inflammatory response to be present, and therefore we're going to use it to our benefit as a marker. To that end, we have what is known as a multi-biomarker panel. We use TK1, and we use either CRP or haptoglobin. And this is a simple Venn diagram where the overlap then would be cancer, because we know that cancer is an inflammatory disease, so we expect this to be elevated, and we expect this to be elevated. Now, sometimes your patients are being treated with steroids. You might have them on dexamethasone, pred, or something of that nature. And steroids are known to be anti-proliferative here, anti-inflammatory here. So does steroids affect our test? Yes. But we have figured out a way, since we've been doing this for a lot of years, how to compensate for that in our neoplasia index, which is the integration of these markers, so that if you are giving steroids to the patient, and make certain you check that off on the test requisition form, the calculation for the neoplasia index will be supportive of the fact that you're giving corticosteroids. Now, the neoplasia index is a calculation, a statistical calculation, where we take TK1 and CRP, digitize it, and put it into unilist values, and then we use logistical regression, and we create an index. The index goes from 0 to 10. 0 being a perfectly normal dog, and 10 being a Perkins score of cancer. And guess what you'll never see in our test? You'll never see a 0, you'll never see a 10, because there's no such thing as perfect anything. And so what we do, though, is optimize it for specificity. So at our cutoff, we're at 90% specificity. And that is important for cancer, because really, what's the question you're asking? You're asking, does this patient have cancer or not? And you want a fairly high degree of certainty in that, and that's what we've tried to work to give you that. Now, have we done a study? Yeah, we've had a number of studies. I think there's 13 published studies, and I'm going to share one of them with you right now. So in this particular study, which was published in the Journal of Veterinary Internal Medicine, was a cohort of 409 dogs, good-sized cohort, 254 cancer-bearing dogs, 156 client-owned dogs. And then we looked at various types of cancers. Now, On the y-axis is the neoplasia index, the calculated score. And then on the x-axis, we have our control group right here: carcinomas, histiocytic sarcoma, hemangiosarcoma, lymphoma, mast cell tumors, melanomas, osteosarcoma, other types of cancers, and sarcomas. And if you look at the neoplasia index across here, you can say, oh my goodness, high scores for lymphoma. And yes, there's a lot of TK that's made in lymphoma. That's how it's got its start, in non-Hodgkin's lymphoma on the human side. But then VDI took that marker, looked at all the solid tumor TK signaling as well, and there's been more done on this on the human side as well. You see a lot more papers on this front. And you can see it works really well in many of these different types of cancers: hemangiosarcoma, histiocytic sarcoma, various types of carcinomas, sarcomas, even what we'll call higher grade mast cell tumors, grade 2 and beyond. And why do I say grade? So tumor grade does affect our markers. Basically, the more advanced the tumor is, the more TK1 inflammation and hence the neoplasia index is going to be. And our markers work really well in moderate to high grade tumors. As you can see in this chart, things just get higher and higher, and the neoplasia index gets higher. And hence it also has a prognostic value, meaning that not only is it more sensitive to these higher grade tumors, but hence since it goes up with higher grade tumors, you're also going to have an index of severity, if you will. So when you have all else being equal, when you have a very high neoplasia index, it's going to mean high certainty of cancer, as well as if TK1 and CRP are quite elevated, that there's a higher risk of adverse effects. All right. And this is the report that we have. You can see here, there's TK1, here's CRP because it's a dog, it would be haptoglobin if it's a cat. Then this one happens to be a high scoring, highly positive, 9.9, which would integrate all the way up so that you know that this is a high grade tumor, if you will. It is context sensitive, so make certain you check off on the TRF everything that's going on with the patient, because we put that into the computer, and all the comments down here are all context sensitive to make it more specific to your patient's needs. We also look to see if there's other things you should be looking at. Now, for example, in this patient, we see that there's moderate inflammation. Now, cancer is an inflammatory disease, but it is also a low inflammatory disease most of the time. When we see moderate high levels of inflammation, it usually means there's something else going on, and we'll flag that right down here, other conditions to evaluate. In this one, we're thinking possibly there might be a secondary infection for you to then look at and consider. So what is this useful for? ADR situations, ain't doing right. The dog has got the signs of cancer, but you're not really sure. You're not seeing anything quite yet. And it's a great triage test. The very first one you should do, because you can tell you whether it's cancer, and because we have an inflammatory marker, if the TK is low and inflammation is high, well, then you know it's some other non-cancerous inflammatory disease. And if everything's normal, well, then you're dealing with a non-inflammatory process that this dog is experiencing. Also, abdominal mass on imaging. The classic would be splenic mass, hemangiosarcoma versus benign scenario. Excellent use of this. Anal sac adenocarcinoma, another one. And hypercalcemia malignancy. You know, you get a chemistry that's got hypercalcemia. You're wondering if it's malignancy because there might be like a calcium generating tumor like lymphoma. And we do have a very nice calcemia panel, which I'll talk about in another presentation, but we also have the cancer panel, and it can be used, one or both, in helping you figure out if this hypercalcemic situation is either like primary hyperparathyroidism or hypercalcemia malignancy, and that would then be an excellent use. Now, for lymphoma, we use a different cutoff because, as you know, as I said, there's a lot of TK that's made with lymphoma. And take a look at this particular example. You can see that TK1 is greater than 100, and this is pretty common in lymphoma cases. Elevated CRP, again, a 9.9. And one of the things that we're doing on these reports now is we're giving you what is known as the CAR ratio. What is CAR? CAR is the CRP albumin ratio. So CRP, of course, is a positive acute phase reactant, so it goes up. Albumin is a negative acute phase reactant. It goes down. And then when you divide the two, the index goes up. And why is this a value? Because if an animal is struggling, it starts losing more and more protein. Inflammation is getting higher and higher. And it might then be a situation where the animal's struggling with the inflammatory response and might be needing additional support. And this is something that, rather than just sending them home, maybe it's something that you need to be doing there for them in order to not only manage the cancer, but also to manage the very drastic inflammatory response that they're experiencing. And so please look at your CAR ratio. It comes with the reports automatically. Now, typical applications are for lymphoma. Of course, you can do FNAs. Very good, easy to do, highly recommended. But sometimes with FNAs, you get equivocal results. You're unable to biopsy. You get insufficient cellularity, in which case then the lymphoma cancer panel can be very useful in these regards, and also can be a wonderful baseline for monitoring. We'll be talking about monitoring later. It is something that I highly recommend that you take a look at our panels for. So in summary, we have different panels for both solid tumors and lymphoma. It's 201 versus 201B. VDI uses a different TK1 for lymphoma because lymphoma makes a lot of TK1, and that's why we do it, to help improve sensitivity and specificity. CAR is a prognostic indicator, something you're going to probably see more and more in the literature. The neoplasic index is adjusted when corticosteroids are used, so make certain you check off the little box on our TRF that says, you're using corticosteroids and what type, dexamethasone, prednisone, whatever it is. And the panel works best in moderate to high-grade tumors. All right. So that is something that I would, certainly recommend in any of these situations where you suspect that, and use it accordingly. Also, monitoring is an excellent use of the panel. And I'll talk about monitoring very soon. So thank you for listening to me.